Hello, everyone. My name is Radwa. I did my presentation this week on osteomyelitis. Osteomyelitis is a serious condition that can be simply defined as a bone infection. Interestingly, archaeologists found evidence of bone infections in animal fossils, which makes osteomyelitis one of the oldest recorded diseases in the history of medicine. This disease, dependent on the source of its infection, can be acute with a sudden onset or mild symptoms, or it can be chronic. This condition can be caused secondary to infections from multiple possible organisms. For example, pyogenic organisms such as Staph aureus bacteria are typically the source of blood bacteria, causing osteomyelitis. Bacteria or fungi organisms enter the circulatory system via an open wound or a nearby infected tissue that can possibly result in a bacterial bloodstream infections that spread to the bone as well as to some of the components of the bone matrix. The biogenic organisms can also land in a bone and multiply, causing inflammation to the bone tissues and its surrounding structures. Additionally, organisms can have a direct portal of entry into an individual's bone as a result of frequent intramuscular injections, traumatic injury, or due to a surgical procedure. Any of these situations can make an individual more susceptible at developing osteomyelitis. In the elderly population, osteomyelitis is often found in the vertebral bone involving the spinal column. However, osteomyelitis affects long bones in children as well as in infants. It can be found mostly in the femur or the humerus. Without immediate medical care or proper treatment, complications can arise. As the infection spreads to the muscles and to the soft tissues, it can cause abscess. People with chronic osteomyelitis are at an increased risk for a recurrent abscess, which places them at an increased risk of skin cancer. In children, osteomyelitis can stunt bone growth in a growing child. Lastly, the inflammation from the bone can impede blood supply to the bone, causing osteonecrosis or bone death. In rare cases, osteonecrosis can lead to the amputation of the affected limb. The pathophysiology. A healthy intact bone is quite resistant against infections. The bone becomes susceptible to diseases when its integrity is compromised. The presence of any foreign surgical object placed into the bone, ischemia, and fractures from trauma can lead to the influence of pyogenic organisms into the bone. The bone sites become exposed, increasing the susceptibility of microorganisms binding to the site, especially in the presence of foreign bodies. Staph aureus bacteria are the most common source of infections to cause osteomyelitis. This bacteria typically adheres to the bone and its structure by expressing receptors called adhesions. Staph aureus receptors can adhere to the bone cellular proteins, laminin, fibronectin, and other collagen. This collagen binding adhesion permits attachment to the bone cartilage, while the role of fibronectin binding adhesion attaches bacteria to the foreign object or any other surgical implanted devices that was introduced into the bone. Additionally, Staph aureus bacteria can survive intracellularly after being internalized by the culture osteoblasts. Other pyrogenic organisms are capable of creating a co-protective biofilm around themselves and underlying surfaces. Staph aureus surviving intracellularly, as well as other organisms having a protective biofilm, is very important as bacteria are now capable of adhering to surgically implanted devices in the bone, in which they can express phenotypic resistance to antibiotic therapy. Moreover, Their ability to survive intracellularly explains their successful persistence to bone infection during shorter courses of antimicrobial treatments. In the case of wheelchair-bound or bed-bound depleted patients, they are at a higher risk for continuous osteomyelitis. One of the main reasons these patients are at a risk is due to their predisposition to developing pressure-related skin ulcers on bony prominence. The underlying bone can become infected from pressure-related skin ulcers, which are typically colonized by polymicrobial flora found in the GI or the skin. For risk factors, there are multiple risk factors to place an individual at a susceptible risk for developing osteomyelitis. Certain conditions, as well as behaviors, can weaken one's immune system. A compromised immune system can also place the individual at an increased risk of developing osteomyelitis. Individuals with a past medical history of any impaired blood circulation disorders, such as frequent blood infections, sickle cell disease, peripheral artery disease, or poorly controlled diabetes, are also at risk for developing osteomyelitis. Those individuals in particular are more susceptible to developing osteomyelitis. Their body's blood supply is compromised and insufficient to circulate white blood cells, especially to their lower extremities. As a result, the impairment of one's blood circulation enables the spread of infection to a site which already has a weakened local immunity. To explain further, the damaged blood vessels are incapable of successfully distributing the body's available infection-fighting cells to the site of the infection in order to halt the growth of the organisms from multiplying and growing larger. As an example, a simple injection can get severely infected and progress to a deep ulcer that may result in unintentionally exposing the individual's deep tissues or even their bone to infections. As stated previously, a weakened immune system will place an individual in a vulnerable state to develop osteomyelitis. There are many conditions as well as medications that may place a person at risk. HIV, cancer treatments, tumor necrosis factor inhibitors, as well as long-term use of corticosteroids will suppress the immune system. With a suppressed immune system, an individual is more predisposed to developing an infection, placing one susceptible to osteomyelitis. In comparison to the normal population, individuals who abuse illicit drugs are placed at a higher risk for infections, as well as developing osteomyelitis. This is likely due to their unsanitary habits of multiple uses of non-sterile needles shared between several individuals. Additionally, they are less likely to sterilize the area of the skin before injections. Such actions introduces direct inoculation of pyogenic organisms into the bone. Although medical procedures are done sterilely, they can still accidentally open path for germs and thus place the individual at an increased risk for infections and ultimately leading to osteomyelitis. Such sterile procedures include inserting tubes such as urinary catheters, dialysis machine tubings, or even central lines into the body. Individuals who underwent any type of metal implant placement in a recent orthopedic surgery due to a severe bone injury or bone fractures are at a major risk for developing an infection. Individuals with artificial joints are also at an increased risk for developing osteomyelitis. Furthermore, an animal bite or a deep puncture wound, for example, from an unclean nail or tooth that has pierced the skin, compromising its integrity, can create the perfect pathway for a severe infection if improper intervention is not provided. People are also at risk for developing osteomyelitis complications. As mentioned earlier, a complication of osteomyelitis can lead to osteonecrosis, as the blood circulation within the bone has been embedded, leading to bone death and surgical removal of the area. Additionally, this condition can impair the growth of the bones or joints in a growing child. Patients with chronic osteomyelitis suffering from open sores due to abscess are at a larger risk of being diagnosed with squamous cell cancer. If the infection is spread to a nearby joint, it places the individual is at risk of developing septic arthritis. For the major signs and symptoms, the clinical representation of acute osteomyelitis can be nonspecific, dependent on the etiology. It is difficult to diagnose this condition as its presenting symptoms may resemble many other medical conditions. Furthermore, patients with chronic osteomyelitis may be asymptomatic, with possible recurrent absence being the only presenting symptom. Although the symptoms may be quite vague, each individual may also experience a variety of symptoms. Acute onset of symptoms may gradually manifest within the course of 2 weeks, depending if symptoms of the infection's onset were rapid or slow. Patients will present with feeling ill, fever, limited movement along with a dull pain to the infected area, warmth, erythema, or swelling to the site of infection, lower back pain or stiff back indicating vertebral osteomyelitis. Others may present with chills, nausea, or vomiting. Patients will usually complain of a new limb or difficulty bearing weight or inability to walk. In patients, they may present with irritability, lethargy, or loss of appetite. Generally, in a subacute presentation, individuals may only have mild pain and generalized malaise. Clinically, patients who complain of fever, worsening back pain, and elevated inflammatory markers should raise the suspicion of osteomyelitis. Additionally, debilitated or diabetic individuals who have been receiving appropriate therapy for several weeks with an unhealed or deep extensive ulcers should also raise the provider's suspicion of possible osteomyelitis. If symptoms were present for longer than 2 weeks, then that constitutes as a chronic osteomyelitis. A crucial part of successfully identifying osteomyelitis is being meticulous during one's physical examination. It should include the assessment of the patient's sensory function along with examining the peripheral vasculature. To diagnose osteomyelitis, it's hard to diagnose osteomyelitis as its symptoms can be broad or asymptomatic. This is true in individuals who have had chronic osteomyelitis, as they may be asymptomatic. Furthermore, the provider must have a high index of suspicion along with the patient's detailed history and physical in order to test for osteomyelitis. Once the provider has assessed the patient's symptoms and performed a detailed physical exam, the treating provider must order a CBC and check for white blood count values as part of the workup in order to check for inflammation markers, such as CRP or ESR. The provider will also order blood cultures on the patient to look for any presence of bacteria in the bloodstream. An order for imaging tests is also necessary. The provider may choose to order ultrasounds, CAT scans, X-rays, and MRIs in order to visualize one's bone, muscle, as well as tissues. The provider may also proceed with a bone scan in order to identify any infections or fractures during the imaging scan. Lastly, a biopsy may be performed as it is extremely useful in the diagnosis of osteomyelitis. During this procedure, a small sample of bone, fluid, or tissue is obtained via needle biopsy to examine it and determine the most appropriate treatment plan for the patient. This concludes my presentation on osteomyelitis. Thank you so much for listening. If you have any questions or any comments, please drop them in the comment section. Thank you so much.